Welcome to Cambridge Health Alliance Health is Wealth. My name is Roberta Robinson. I'm Director of Marketing and Outreach for the Geriatric Division of the Cambridge Health Alliance. And today we have with us Dr. Reformat. And Dr. Reformat is a plastic surgeon.
That's correct.
With the Alliance. So welcome aboard. Thank you so much for coming on board.
Well, thank you for having me, Roberta.
So this is a topic that maybe we read about. Maybe we read about with movie stars. Maybe we have had some experience with it. And so we definitely, this is my first time having any topic like this on the show, so thank you. We're broadening our horizons here. So tell us the kinds of plastic surgery. We all know what plastic surgery is, right? Is there a definition of plastic surgery?
Sure. So plastic surgery can be either reconstructive surgery, or it can be cosmetic or aesthetic surgery. That's commonly what many of us think plastic surgery is. The cosmetic surgery or aesthetic surgery really is surgery where you're trying to improve upon normal, whereas in reconstructive surgery,
like a facelift or
like a facelift or what you call a nose job.
Nose job.
That's correct.
Okay.
Whereas in reconstructive surgery, you're really just trying to restore normal. Somebody's coming to you with some kind of aberrant anatomy, some kind of defect, and you're really just trying to restore what we would consider normal.
So that would be specifically after, say, breast surgery, reconstructive surgery, and then you would make. I guess then you have your you can have your own wish list. Then you can decide whether you want to be the way you were or smaller or larger.
That's correct. So yes, while patients come in, and you brought up breasts as an example, if a patient has their breast removed, let's say for breast cancer, for example, it is an opportunity for the patient to restore the breasts that the patient came in with or make something different.
So how is that done?
Well, so
I think maybe, and you know, it's a scary thing. There's a lot of talk about breast cancer, and it is a frightening thing. And so if you get it, there you can elect to have reconstructive surgery, right, and they do it right after, right then and there.
It depends, but yes, it can be done right away. I'm fortunate enough to work at Cambridge Hospital, which is considered an accredited breast center. And so as such, it offers a full gamut of reconstructive options for patients after breast cancer surgery. So that surgery could be immediate. It could be several weeks after the mastectomy is performed, or it could even be performed months or even years after.
Really? So what would dictate the timing? What the healing? How well you healed after the surgery? Or?
Some of it is dictated by the pathology that the patient or the person's coming in with. So if the patient, for example, needs chemotherapy for breast cancer before surgery, that may impact what we're going to be able to offer that patient. Conversely, after surgery, if a patient needs radiation therapy, that may also affect the timing and also the recommendations for what type of reconstruction to get.
Ah, I see. So it is all very interesting, isn't it? And it's fabulous that we're able to do things like that for the women today that have had to go undergo mastectomy. I know that they don't necessarily, I think, they're not as radical about mastectomies today as they were, say, 20 years ago. I think they try not to be as invasive these days. Is that correct?
Yeah, that's interesting choice of words, radical, because the initial mastectomy that was originally described over 100 years ago, the radical mastectomy, involved removing not only the breast, but also the chest muscle underneath. And so it involved really removing almost the entire chest. And so we've come away from that. In fact, we've gotten to a point within the last 10 or 15 years to a point where we found that it's safe to leave behind not just the breast skin, but even the nipple in some select cases.
Really? Wow. So then when you reconstruct, what do you use?
Well, so when patients come in and they ask me, doc, I'm going to be undergoing breast surgery, I will offer them 4 choices. First and foremost, patient can elect not to undergo breast reconstruction. If she says, I just want to have the breast removed, she wants to wear a prosthesis, for example, afterwards, or if in the case if she's having both breasts removed or a bilateral procedure, she can elect to have no reconstruction. And some patients do that. So that is certainly option number one. It's simple. It just involves closing the breast skin after the mastectomy, and that is available to patients. And I, even though they're coming to see me because they may have some interest in reconstruction, I do have to remind them that it is still an option for them. So option number one is to do nothing. Option number two is an implant-based reconstruction. So you may hear about implants, breast implants. Commonly, we think about them for cosmetic procedures, but silicone implants, implants
First word that came to my mind.
Silicone implants, they're made out of gel, and there's also saline implants or saltwater implants, which are also made with a silicone shell but are filled with salt water. Both of these implants are safe, and they're a way for us to reconstruct the breast mound after mastectomy.
So then in the case that you could save the skin, you would just put the implant in and then put the skin right over?
And put the skin right over, that's correct. If you're leaving behind the nipple, you might even be able to put in the full-size implant and reconstruct the breast in one sitting. Some instances where you're having to remove the nipple or remove a little bit more skin, you may not have that full envelope to recreate the full breast.
All right.
So you may have to stage the procedure. And so in that instance, you're placing a temporary implant in at the time of mastectomy, filling it with salt water over time so that it stretches the skin, and then at a later surgery, putting in a permanent implant, whether that's a saltwater implant or a gel implant.
Wow. I had no idea.
So it can be multiple surgeries. We like to try to limit the amount of surgeries, but it could potentially be a staged procedure with multiple procedures.
And so do you reconstruct the nipple at all when there is
so
no nipple?
that comes that could be done potentially under local anesthesia in the office, or potentially if there's revisions that are necessary or other surgeries, touch-ups, that will be done in the operating room. So that's option number two. Option number three would be to use your own tissue.
To what?
Use your own tissue.
Okay.
And so that
Other parts of your body?
That means transferring tissue from other parts of your body, rotating it into the breast to recreate the breast.
Wouldn't that need a lot of tissue?
So you are creating new scars on other parts of the body, and that is commonly one of the downsides of that type of surgery. But one of the benefits is that the tissue tends to feel and look more natural, like a breast.
Now, as you're just mentioning the tissue and using your own tissue, is there any rejection of any materials when you use like the silicone or saline or gel implants?
So with the implants, everybody forms, there's no rejection, but there is a reaction.
Okay.
And so everybody forms what's called a capsule around the implant, and that's completely normal.
Okay.
Sometimes what's not normal is if the capsule acts like a muscle around the implant and starts to contract. And so that can be a common reason why patients may need surgery in the future if they've had implants placed in the past, whether that was for reconstruction or for cosmetic surgery.
Oh, so it can happen
Regardless.
Right.
The body will react to a foreign body the same way. It forms a capsule around it. So those same patients who have ports placed, for example, for their chemotherapy, will also form a capsule around the port. It's just the normal reaction.
Yeah, sending things there to protect, right?
In terms of your tissue, you'll never reject your own tissue.
Okay.
But what can happen, one of the downsides or one of the things that we have to look out as surgeons performing these, what we call autologous procedures, using your own tissue, is to maintain blood flow to that tissue. Blood flow is very important to the plastic surgeon.
So when you take tissue from one place and put it to another, how does that happen?
Well, you can do it. You can do it a couple ways. You can rotate it along a muscle that contains an artery and a vein, or you can even take it off the body with an artery and a vein. You have to plug it back in to an artery and a vein in the chest.
And what do you do with the artery and the vein?
Under a microscope, you put them together.
Oh, yeah. That's tedious.
It can be very tedious. It can be. And so us surgeons will get together with other surgeons and form teams and work simultaneously on different parts of the body if we can squeeze in. Just like you and I are squeezing in right now.
Right. So how long, so you have a plastic surgery. So surgery removes the breast for a mastectomy. And then at some designated time, whether it's right in the OR or if it has to wait. And is that determined at the time of surgery, or do you folks know ahead of time?
We try to come up with a definitive plan ahead of time.
Ahead of time.
And
Well,
so it's a lot of, it can be a lot of back and forth between the patient and the breast surgeon, or the patient and the plastic surgeon, and then the breast surgeon and the plastic surgeon have to all come up with a plan that's appropriate for that patient.
so everything goes smoothly at the time of the operation.
And we know exactly what we're going to do that morning.
Right. So is there a set or a usual amount of time that it takes for breast reconstruction? Or is everyone so different? Every case is so different?
You're talking about in terms of the operating room or just overall?
Yes, the operating room, to actually either put the implant in, or I would think it probably is less time to put an implant in than it is to take your own tissue. You're the doctors that take the tissue.
Correct.
Right.
So you're right. It does potentially make the surgery for reconstruction a bit longer if you are using your own tissue. You have to first, of course, make sure the breast pocket is ready to accept the tissue, and then you have to go ahead and dissect the tissue, and then go ahead and rotate it or place it into the chest. So it can be longer surgery. Yeah, can be longer surgery. Can be a longer hospital stay. But then potentially, if you look at it long term, you don't have a foreign body, so potentially don't need to refresh that implant in 15 or 20 years.
So, do a lot of people elect to use their own tissue?
So interestingly, if you look at the data nationwide, 80% of patients who undergo breast reconstruction choose to use implants.
Right. I would have guessed that. I would have guessed that only because now you have a few other parts in your body that are going to be sore.
A lot of patients don't like the idea of putting scars elsewhere on their body. That said, if you do use the abdominal tissue, depending on the patient, it can be considered a tummy tuck. It's the same procedure.
There's a benefit to that. I was thinking about that actually. So you could have a twofer.
That's correct. Yes.
Right. Interesting. Okay, so now.
And then I'll say, let me ask,
yes,
the fourth option
yes.
is to use a combination of the implant and your own tissue. Let's say a patient comes in and she's very skinny, but she wants to use her own tissue, but she also desires a certain volume of breast. It may be advantageous for us to use both her tissue and also to place a small implant.
She wouldn't need a tummy tuck.
Potentially not.
Right. So would you go for the thighs or the heavier
So there are some
parts of the body?
There are some specialized surgeries, especially the microsurgery, where you can start to use the buttock, the thigh tissue to recreate the breast.
Right. All the heaviest parts of the body, so she would not be depleted totally. Well, all these choices we have, and who knew? I had no idea, but that's why I do the show. Now, we talked about, is there anything else around the breast reconstruction or the breast surgery that I might not even know enough to ask?
Well, you mentioned the nipple reconstruction. That, like I said, that can be done either in the office or in the operating room, either as a third surgery or a procedure in the office. And then in addition to that, there is tattooing available that will create the areola, the darkened skin around the nipple, just to further recreate that
So
breast
visually
aesthetic.
it looks the same?
And there are even some tattoo artists who specialize in creating areolae with the nipple in 3D. So patients may not even elect to undergo nipple reconstruction because they've got a tattoo that makes it look as though they have a nipple.
So is that done at a totally separate time at the tattoo artist? They don't come into the OR and do that,
They do not. No, that would be done in the office.
In a plastic surgeon's
It could be a
office?
plastic surgeon's office, it could be the physician, it could be a medical assistant, it could be a physician assistant, or it could be a tattoo artist.
Who knew? Who knew? So there are a lot of different options that people have. So it's not just you get this or nothing. There are a lot of different options, which we've come a long way.
That's correct.
Haven't we? And as I mentioned to you before the show, I had a friend in the 80s and we've come a long way since the 80s. That's good. So we get to choose what it is we like. Now, do most of your patients choose reconstruction, or is it about half and half that might not do it, or?
Most of the patients who've made it to me are interested in at least hearing about reconstruction. I would say maybe about between 2 and 5% of patients will elect not to have a reconstruction.
Okay, small percentage.
Very small.
So is after mastectomy, I would hope that the reconstruction would be covered by insurance, is it?
It is, and in fact, so any procedure related to the breast cancer, the reconstruction after the mastectomy is all covered by insurance.
Okay.
But in addition to that, if, let's say, for example, the breast cancer and the breast surgery is only going to be on one side, to help make symmetry between breasts, if the other breast, the unaffected breast, is asymmetric to the other reconstructed breast, insurance will also pay for a breast lift or even an augmentation or a increase in the breast size if it's going to improve the symmetry. In that instance, it's considered a reconstructive procedure.
And so that's an important point, that it's covered by insurance. We wanted to definitely. Now, what about if someone elected to do the tattoo artist? Because that is part of
Also covered.
Also covered. Okay. So that's all good to know, that you have your choices and it's all covered. Not that we would want to have to go through it, but if we have to go through it, we know we have choices. That's great. Is there anything else that we need to know that I might not know enough to ask?
If the patient is going to go, this is a little bit more advanced, but if the patient is going to have radiation therapy down the line, it does put the patient at a bit higher risk of having problems after surgery. And so we do want to be very careful with those patients if we're using implants. And in some instances, I may recommend, or I may strongly try to urge the patient to consider using their own tissue, because there you're bringing non-radiated tissue to the field to recreate that breast. And that helps the surrounding radiated tissue. Radiation is very good at killing breast cancer, but it's also the side effect of hurting the normal tissue that lies around the breast.
Right. It can't just isolate and do the breast cancer. It does everything around.
Unfortunately, we don't always know if the patient's going to need radiation until after the mastectomy, until after the pathologists have looked at the tissue under a microscope in the
to
lab.
see if there's anything left.
If there's lymph nodes involved, or if there's any cancer left, or at the margins, for example.
Okay.
So radiation.
Okay.
Not
Radiation.
not the plastic surgeon's friend.
Okay. So, but if we need it, we need it to
That's right.
Destroy the cancer
Right.
cells.
We always understand that beating the cancer, curing cancer is the #1 priority, and reconstructing the breast comes after that.
That's right. We want to stay alive here, and that's the way to do it, right?
That's right.
Right. Anything else I might be missing?
I think that's it.
Okay. So you mentioned aesthetic or cosmetic surgery. I think most of us know, we've seen movie stars with, and that might be the Botox with the lip. That's especially around the lip area, right? Or the eye?
Actually, right. So it's actually the eye. So
Oh.
Botox is it's a neurotoxin that's used to paralyze the muscles of the face in this instance. And the FDA has approved it for use in just 2 areas of the face, at the corner of the eye, and then also in between the eyebrows. Everywhere else it's considered off-label. Now that doesn't mean it's not necessarily safe, it just means it hasn't been studied for those particular purposes.
Okay.
And so the reason you would use Botox is to eliminate wrinkles. And to
like crow's feet?
Exactly, crow's feet, and we use the term glabellar lines, these lines that are the frown lines that run vertically between the eyebrows. So if you're trying to smooth those lines, or you're trying to completely efface them, you would consider using Botox to paralyze those muscles that are attaching to the skin, causing those wrinkles. Because wrinkles really are just attachments of the muscle.
So they just stay paralyzed?
They stay paralyzed. The medication works well for 3 months to 6 months. So it's temporary.
That's it?
That's it.
Okay.
That keeps the
And that's
plastic
an
surgeon
injection?
that keeps the plastic surgeon in business.
Right. Right. Oh, well. So that's an injection
That is an injection that's done in the office.
in the office. Sterile? I would guess.
Sterilely.
Yeah.
We consider it aseptic technique since it's not considered in the operating room. It is clean, but it's not considered sterile.
Okay. So what about the lips though? Isn't that Botox?
So you can do Botox potentially for turning lips up, the corners of lips up, the corner of lip down, if patients have excessive muscle working around the mouth. More commonly, we'll use fillers around the lips.
Oh, to plump them
either
up?
plump them up or to fill those
I
wrinkles.
mean, I have no lips, really. So here I'm sitting with a plastic surgeon. But, so that would be to like plump and give you...
Either plump or, again, similarly to try to efface wrinkles that are already present, smooth out depressions, if there's any depressions. Commonly, patients will ask for filler along the
laugh lines.
The laugh lines going all the way down to the jaw. Sometimes you'll also have patients who want cheekbones, more
Defined.
volume at the cheekbone.
Yeah.
What happens as the face ages is that gravity, just like the rest of the body,
Gravity takes
pulls
over.
everything, and gravity will win ultimately. It's a battle that plastic surgeons can't win ultimately, but in the meantime, we do try to fight gravity, and so a lot of the things we do are really to sculpture against gravity.
So, and a lot of times people will, I'm speaking, my only frame of reference is with celebrities. So a lot of times I would guess they would elect to do all of those procedures that we just talked about.
Potentially.
Not insurance covered.
Not insurance covered.
No, that's out of pocket because you're electing to do that. Is
That's
that
correct.
right? Okay. So sheer cosmetic. Now, in some instances, and I can think of a few horror shows, that people don't even look anything like they did. Is that because they've done it too many times, or too much was put in?
It's really up to the patient. That may be their desired effect. It could be the result of too much plastic surgery. It really is up to the patient to delineate and tell the plastic surgeon what is it that bothers them about whatever particular appearance that bothers them. Really, they're the ones driving the problem. They're the ones identifying what is the problem, and I'm the one to tell them if I have a solution.
And sometimes we don't know. Right?
Sometimes we don't have a solution.
But sometimes the people that are with their wish list have no idea what they're asking.
Right, so some patients will come in and they'll say, "Doc, can you fix me?" And I can't fix you. You have to tell me what it is that's really bothering you. And if you ask a few more questions, a little more closed-ended questions, you may be able to elicit something. But if a patient comes in with a generalized complaint of, "I just don't like the way I look," that's going to be very difficult to address. You really have to narrow it down.
So, and then there's a facelift, right?
There's a facelift. That's the ultimate, right, for fighting gravity.
So what do they do? Cut here and pull up?
So incisions are commonly made. There are different ways to do a facelift, but most commonly, the traditional facelift involves making incisions in the front and behind the ear, even back into the hairline. A facelift will commonly be performed in conjunction with a neck lift, where you're pulling the skin as well as the skin of the lower 2/3
So
of the face.
you just pull it back.
So you're pulling skin. There are ways to make the skin with time is always going to stretch. So if you limit your procedures to skin only, over time they are going to fall again.
Okay.
So to try to make our results a little more permanent, we may do some work on the underlying musculature that's underneath the skin.
Okay. So we have a few more minutes. As I was perusing your site, I came across something that I'm not familiar with, or I wasn't. I'm more familiar with now. This Coolsculpting technique.
That's correct. So Coolsculpting is a non-invasive way to contour various parts of the body.
So there is no cutting, there is no surgery.
This is considered not surgery. This is considered an office-based procedure.
Okay.
And it involves applying a applicator, a device that can be that big or about that big, and you're identifying parts of the body that you think have excessive amounts of fat.
Okay.
And you're basically applying a vacuum to that area, and then freezing the fat
So
within that.
so the vacuum localizes it?
The vacuum will localize the area that you want to address, and it will freeze the fat while protecting the skin.
So then what happens?
So you freeze the fat, and then over 3 weeks to 3 months, fat cells die.
Oh.
And
And how do you just flush them through your body? How does that
your
work?
your body recycles it,
Your
and
bo-
so you
Recycles it to what?
recycles it to your urine.
Not more fat.
No, not more fat. Not more fat. You will not gain fat in other parts of the body. This fat dies, and that's a permanent effect. Of course, unless you're gaining weight, generally.
Right. So so when you localize that, does it change the look of you until those fat cells die and go?
Yeah. So like I said, it takes about 3 weeks to notice results, but you can.
But it has to, because it's pulling it all. I mean, I don't know, but it seems like it has to.
Yeah.
Because you're localizing it, you're pulling it.
You are a little bit dependent on the skin retracting over that area. You know, the fat is going to stretch the skin out. So somebody who's coming in just with, let's say they've lost a lot of excess weight already, and they're coming in really just with excess skin, those would not be good candidates for Coolsculpt.
Oh.
Because the excess skin is not being addressed by the Coolsculpt. It's the fat,
The
underlying
fat cells. Okay, the fat
And so we're
cells.
always-
So that'd be two different procedures.
We are always looking at ratios of fat to skin when dealing with body contouring.
Okay.
So then the more invasive procedures other than Coolsculpt would be either liposuction, which is surgery,
Oh, right.
or if you have a lot of excess skin, in that case, having to cut it out with surgery.
And that's not covered by insurance.
It depends.
If it's medically necessary?
It depends. There are a certain few instances where it may become medically necessary.